Computer, perfect. يلا. Okay, guys. So this class is basically I've taken this from a very good collaborator of mine. It's Dr. Juha Grolholm. Juha Grolholm is basically he's an MD, but also he's a researcher in Finland. So he works at HUS, which is the Helsinki Yliopiston Sairaala, which is the Helsinki University, basically university. It's a huge complex that is basically tied to the University of Helsinki. So he works in both. And Juha does a lot of really cool work in where he is an MD. He's mostly in the pediatrics section and where he works with primary immune deficiencies. So mostly kids that do not have a proper immune system. And in very many cases, he actually gets people that have a weird disease, that they have a primary deficiency, but it's not really, it's very atypical. Yani, the symptoms are not standard. يعني it's not what you see in the, let's say, immunology book or in the medical book. فhe does a lot of research on it. وأنا كتير بساعده because I am very interested in immunology, not just in cancer, but just as immunology. For me and him, we do a lot of collaborations. We've published now basically two papers, and now our third one is coming out about many cool cases اللي عم بيطلعوا. I asked him if I can use his. He basically I do also the same course but more pure immunology بهلسنكي. He gives this course there. قلت له can I use it here? He let me. So that's why I need to kind of give him credit for this. So مثل نحن بنعرف in the immune system we all start from a stem cell, this hematopoietic stem cell. How stem cell, this can have the ability to actually give us the whole immune system. يعني it literally can divide, so it can divide into your myeloid progenitors and your lymphoid progenitors. From your myeloid, we know that you get basically your mast cells, monocytes, eosinophils, basophils, neutrophils, etc. And we know from the lymphoids, we get basically our NK cells, our T cells, and our B cells. For we basically know that all of them come from this one type of stem cell. And when we basically get divided into these many different types of immune cells, we technically have four main arms. We call them four arms of the immune system. The first part is the phagocytosis. So these are literally your phagocytes. These are the ones that are eating up. Yani these could be your monocytes, these could be your macrophages, these could be your neutrophils, anything that basically eats up. And these cells are extremely good at eating anything that is extracellular. Yani, if you think about it, a phagocyte will only eat something that is outside. It's not going to eat up a whole cell that has a virus inside. No, that's very rare. So it's much more helping us in combating extracellular bacteria and specifically Staphylococcus. Staphylococcus is this very nasty bacteria that causes a lot of abscesses and lymphadenitis. Very annoying ones. They actually in I think 50-60% of them of people, you have Staphylococcus actually living up in your nose. So it's a very nasty bacteria. Then you have complement. Complement, as we know, very great at doing this MAC complexes that destroy membranes. But complement is very good, specifically with bacteria that are not able to be phagocytosed. And these are bacteria that are encapsulated. Maybe you guys have took it in microbiology or something, but there's a lot of bacteria. What they do to kind of, let's say, evade your immune system, they have a capsule, a sugar capsule around it that doesn't allow any phagocyte to come and actually kill it. So what happens is that now this encapsulated bacteria is not able to be recognized by phagocytes. Your complement is able to do that. So your complement system is very great at that. And your complement system really is very, very good against Neisseria meningitis. Neisseria meningitis is a very nasty um, bacteria. It's basically, it infects the meninges. So meninges is these three layers that are right above your brain, and it can cause very harmful inflammation there to the point it can spread into your brain and can cause death. Actually, just last week or 2 weeks ago in my old university, University of Kent, there was an outbreak of Neisseria meningitis, and sadly, one student died. There was, for some reason, people don't know, but Neisseria was basically just in the water, and people started to get infected. So now they've done a huge, basically, vaccine response to that. Then you have the adaptive immune system. Your adaptive, there's two types. There is your antibodies, so the humoral, we call them. And these are basically mostly binding again against bacteria and more specifically bacteria that are encapsulated as well. So these are like, for example, staphylococcal infections, pneumococcal, mostly pneumococcal. These are pneumonitis, streptococcus pneumonia that really cause, again, as the name says, pneumonia. These can be very encapsulated. Again, phagocytes are not really able to kind of recognize them. So your antibodies are very good at that. And then you have T cells. T cells are very good in a sense of more not extracellular, because we know that specifically your cellular T cells, these are mostly your CD8 T cells, they like to kill something that is inside. They kill, for example, viral infected cells. So a cell that has a virus, because the cell that is infected will present a viral antigen in its MHC1. CD8 comes in, it recognizes it, and it kills it. So T cells are very good at that. And also, they're very good at fungal infections, Candida and Aspergillus, because Candida and Aspergillus are very, very big. They're not really, complement cannot really detect them. Antibodies can detect them, but don't do much to them. Phagocytes, they really cannot really eat up such a big microorganism. So that's why T cells really can't take this up. So by knowing, let's say, the strengths of these, let's say, arms of the immune system, when we get, for example, cases in the clinic, for example, we get someone that we see that this kid is having a lot of Neisseria meningitis infections, a lot of it, especially recurrent. You can already say that, hey, I think this guy has an issue with your complement system because complement system is very good against Neisseria. Or we see that this kid is having a lot of issues with Staphylococcus. Staphylococcus. Maybe he has an issue with phagocytes or has an issue with your antibodies. So by knowing the strengths of these immune cells, you can definitely sometimes already know if what the symptoms of this kid has. You can already say what, let's say, deficiency this guy has in his immune system. So this is what actually Juha Grolom and other doctors do. So now let's go into what immunodeficiency is. Immunodeficiency is technically a state in where your immune system, so the immune system's ability to fight infectious diseases, is absent or compromised. Absent meaning that it doesn't exist. Compromised could be that it's not working as good as it should be, or it's actually working better than it should be, but to the point of causing inflammation. So your immune system, it's good that it's working, but sometimes if it works too much, it can do too much damage. So immunodeficiencies there is more like in the sense of like either it's absent or it's basically compromised. And compromise can mean two different things. So there's two types of immunodeficiencies. There's called primary immunodeficiencies, PIDs, which we also call them inborn errors of immunity. And the name kind of says, it's an inborn error. It means you have a genetic mutation. You have a mutation that for some reason it's affecting your immune system. And there's literally more than 550 monogenic diseases identified. So there's so many mutations, and it keeps growing, by the way. It's not set. Me and Yuha discovered a new mutation, literally, mostly Yuha, I would say, discovered it like 4 years ago on this Finnish kid. So they keep growing and growing and growing. And these primary immunodeficiencies, they usually manifest during childhood very early on because, again, as you develop as a kid, you don't have, let's say, a arm of your immune system. So you aren't generally actually deficient and you can have recurrent infections. So these recurrent infections already can tell us like, hey, you're having an issue. So we already see them in your childhood. It's usually childhood. There's only maybe one common disease. There's common variable immunodeficiency, CVID, which affects more your antibodies. Your antibody, any deficiency that affects your antibodies, you usually see them early in your adulthood. And this kind of tells you that antibodies are important, not a lot in your childhood, because most probably your other arms of your immune system can take over, but later on, they become much more important. So it's usually most of these primary immunodeficiencies happen a bit later. Sorry, happen more during your childhood. It's only more the B cells that happen a bit later in your early adulthood. And then you have secondary immunodeficiencies. These are more acquired. Yeah, and these are basically, for example, if you're infected with HIV. We know HIV, one thing that it does very well is it really disrupts your CD4 T cell compartment. It literally kills them off. So you actually have now a person that is immunodeficient. Hence, we call this acquired immunodeficiency syndrome. So this is what AIDS stands for. This could be also lymphoid malignancies. You can have a cancer in your own immune system that now there are these immune cells. For example, you have cancer in your B cells. Well, these B cells are not actually functioning well anymore. So you have a defect in your B cells. This could be also from other causes like immunosuppressive medication. When we are under transplant, we're taking a lot of immunosuppressive meds. Our immune system is basically shut down and basically is compromised. Chemotherapy does affect a lot our immune system. Splenectomies, when you remove the whole spleen, the spleen is a big source of where a lot of basically our immune cells are there to basically, let's say, to mature and everything. Now it's gone. Malnutrition, alcoholism, pregnancy, all these things can actually affect our immune system and can cause things to be compromised. But the thing about secondary immunodeficiencies, they can manifest in any age, depending what you get. But also, the thing about them is that they are reversible, meaning that if you're able to tackle any of these, then basically you fix your immune system because this is the root that's causing the compromise. Well, in this case, it's a genetic defect. Unless you're able to change the genetic defect, then you make it reversible. Well, this is very hard. This one is much more easier. Of course, except HIV, because we know HIV, it stays there for life. There has been now cases where people have been cured for HIV because they've done some way genetically edited the whole HIV genome out. So when it comes to clinical manifestations of, let's say, EIE, so I'm going to be talking a lot mostly about primary immunodeficiencies. So these are inborn errors of immunity. Mostly what we see when someone comes into our clinic, we get to see is mostly you have infections. And the type of infection really guides us to tell us like, hey, what part of the immune system is being deficient? So as we said, if you have pyrogenic or pus-forming bacteria infections quite constantly as a kid, it tells us that maybe this is okay. This is extracellular bacteria. T cells do not really kill extracellular bacteria. This is more on the level of antibodies, complement, your phagocytes. If we see a kid having more fungal infections or more viral infections, we see that these ones, antibodies and phagocytes and complement, don't really go there. It's mostly T cells that kill that. So you're already going to your D cell defect. So you see basically mostly, of course, the biggest thing is that infections and the type of infection tells us like, hey, what kind of defect we're getting. But you also see syndromic features. Syndromic features basically means you have issues with development and behavior. These are features you see basically with people with trisomies, like Down syndrome, Edwards syndrome. These are these kind of, let's say, symptoms. You also see autoimmune and autoinflammatory conditions. This might seem a bit like, counterproductive because in a lot of cases, a lot of the time, the immune system is so defective. How is it, how is there an autoimmune disease? How is there an autoinflammatory? Well, it is very, very common, and we'll talk about why you get these things actually. It's very interesting for me. Then you also get early onset of atopy. Atopy is basically allergies. So that's what you get a lot of allergies technically. You also have a failure to thrive, and you also have an increased susceptibility to cancer. Because, of course, your immune system has a very crucial, let's say, kind of role in protecting us against cancer. So here, this is in red because I don't need you guys to memorize this. This is just for your own information. So there was a very nice study done by the Journal of Allergy and Clinical Immunology, and they showed that in a European cohort of 21,000 patients, mostly the most type of manifestations you get in 68% of the patient is infections. Then you get syndromic features, immune dysregulation, infections, and and then malignancy. So this is basically this kind of type of things that you get. So as we know, an immune system balance is extremely key because we know you push your immune system too much, especially it will help you for infections. It will help you actually fight infections. but it can cause autoimmunity and autoinflammation. And of course, if we suppress too much your immune system, infections goes up, but also cancer. But surprisingly, also autoimmunity can come up in here. And we'll be talking about this immune system and this balance very well today, specifically in the context of primary immunodeficiency. But before we go into primary immune deficiencies, I need you to guys to know a bit of terminology. So maybe this is something you guys have taken in genetics, but let's go for this recap. So we have loss of function mutations. These are mutations that are literally basically causing some way a nonsense, a frame shift, splice site, or a deleterious missense mutation in a sense that your protein that now the gene is encoding for is lost, or basically its normal activity is not there anymore. So you basically have an absence or dysfunction of that basically gene, a protein that is doing some sort of immune defense. Haploinsufficiency, this happens when technically you have two copies of a gene, right? So haploinsufficiency is meaning that one copy of that gene is mutated, and because that one copy, the protein that comes out is basically not functional because it needs both copies. So that's what we mean by haploinsufficiency. So when one functional copy of the gene is not enough. So this is basically when you see one um, one gene that's mutated and it's gone, but the other copy of the gene is still fine, but it's not enough. And you see this quite a lot with transcription factors and structural proteins. We also see dominant negative variants. These are literally mutations that they interfere with the normal wild type allele, so with the function. So the difference between dominant negative and loss of function, technically, it really pushes down the expression. It really lowers the amount of protein, or it makes it very crippled. While dominant negative, the protein is still there, but it doesn't work really that well. It's there, but not there and there. Then you have gain of function. This is almost the complete opposite of the dominant in a sense where now this mutation is making it excessive. It's completely pushing it to very high, so it's gaining a function. And again, even though it's working so much, it doesn't mean that your immune system is working well. If something works too much, it can actually have an opposite effect. So again, everything is a balance. You need to be very careful with how much that balance has to be. So there we have a lot of these gain of functions variants, and we'll definitely talk about them today. Then you have mutations that are in the non-coding regions. We call these regulatory or expression level defects. So these are mutations that affect the gene product, but the mutation is not in the gene per se, it's in enhancers or promoters. So this mutation is really affecting the expression of it, so the transcription of that. Because as we know, there's enhancers and promoters in these non-coding regions that are helping your basically transcription machinery to transcribe a whole gene. And you have a mutation that now suddenly they're not working and they're not bringing your transcription machinery anymore. And then you have somatic/mosaic variants. These are mutations that happen after fertilization. So they're not passed on by your mother or your father. They basically only occur in some cells. So for some reason, we are acquiring a mutation either by basically by pure chance that a DNA damage occurs, or basically there's a error during basic transcription or during DNA repair, or that we acquire through basically we inhale UV, smoke or something. And certain cells, only certain, not all of them, some cells get that defect. And that's called somatic mosaic variants. So one thing that's also interesting is that despite that you might have a mutation in one gene, this doesn't mean that you will have this basically one phenotype. So one gene mutation, so if you have one mutated gene, it doesn't mean that you'll have the same phenotype. No, you get so many different types of phenotypes because as we said, there can be so many different mutations. There can be a gain of function or loss of function mutation in the same gene, gives you completely two different phenotypes. It's very rare that you have one gene, if you get a mutation of one gene, gives you basically the same phenotype. It's very rare. Give you examples, and again, these are in red. These are just for your own basically interest. So I'll give you an example here. STAT3. STAT3 is a very important transcription factor for B cells. We see basically loss of function mutations in STAT3. You get hyper IgE syndrome, meaning that now suddenly the B cells can only produce IgE. You have gain of function. Suddenly you have basically these B cells are so reactive. They start to create so many different types of antibodies, but it gives you more autoimmunity and more susceptible to infections because the antibodies that you're creating, even though they're a lot, they're not the greatest. They're much more targeted against organs. So two different mutations given in the same gene, but different outcomes. Another one is, for example, CARD11. If you have a loss of function, you get combined immunodeficiency. If you have basically double negative variants, you get eczema. If you have gain of function, you have actually more B cell lymphoproliferative diseases. So, for example, more in the cancer spectrum. Again, different. Here, this is another example. Basically, here you have COPA, a very important immune gene. So if this is in the N terminal and the basically N terminal, there's a mutation in its N terminus, you get arthritis. If it's in the C terminus, you get basically, for example, autoimmunity. So again, it doesn't mean that if one gene is mutated, you have basically the same phenotypes. No, different mutations within one gene can give you multiple different types of phenotypes. So when it comes to the distribution of primary immunodeficiencies, the big majority, so almost up to 70%, is coming from your B cell. The majority of them coming from B cells. And specifically, you have some way a deficiency in IgA. That's the most common one. But then, of course, this is followed by T and B cell defects. So where you have defects in both your T and B cells, which we're going to be talking about today a lot, phagocytes, T cell defects, and complement. Complement defect, it says here 5%. This is, I would say, Juha told me that he thinks this is very mythical. This is not true. And he thinks this is because he's seen a lot of people that do not have any clinical manifestations. They have no symptoms, but they have a defect. And he thinks that the complement system, as important as it is, a lot of its functions can be actually taken over by your antibodies, by your phagocytes. So having a defect in your complement doesn't really put you in a lot of danger. So he thinks that there's a huge portion of people that are living with a defect in their complement system, but they really don't know. So this is why he thinks that this 5% is not really, let's say, 100% true. He thinks that there's a lot of people that are out there having complement defects in some sort of way or not. So as we said, the onset, the majority, or the clear majority, start very early. We're talking almost literally between less than 1 year and 1 year and five, and basically five, that you get these symptoms. It's only the CVID, there's basically this B cell where you have defects in your B cells, that they start a bit later in some sort of way. So because as we said, antibodies, as important as they are, maybe during our childhood, we really rely on your complement system, your phagocytes, your T cells, your NK cells, these kind of other ones. Well, later your B cells start to become much more important a bit later on. And this makes sense because actually B cells is one of the last immune cells actually that are being, let's say, let's not acquired, but more matured. So that's why actually we have to have breast milk to almost 6 months because our B cells, they take quite a long time actually for them to be, let's say, more mature because we get antibodies basically from breast milk during those stages. So maybe that's why the common variable, these B cell deficiencies are not really seen maybe until a bit later on. So now let's start into different types of diseases. Let's go into the clinic. And I'm going to start with B and T cell deficiencies. We call these severe combined immunodeficiency. So the name says it all. It's severe, it's combined, meaning you have a deficiency in both your B and your T cells. And these are very severe. So this is one of a patient called David Philip Vetter. Maybe you guys have seen, actually, they made a movie for him. It's called Bubble Boy, or the Boy in the Bubble, I think it's called, the movie. It's a very old movie. This kid, technically, doesn't have any B cells or any T cells. So technically, he has no adaptive immune system. And this is very dangerous to the point that this kid, from any infection, he could die. You cough on this boy, he might die. This is how severe it is. So this boy, they called him the boy in the bubble because he literally was put in a bubble because he had to be surrounded, or basically, sorry, he had to be put in a more isolated kind of bubble away from the environment because the environment could kill him. This boy basically got a transplant. So he basically got a hematopoietic stem cell transplant. He got back his T and B cells, but sadly, the transplant that he got, the hematopoietic stem cells that he got, were infected with EBV, and the EBV killed him right before his immune cells were able to get it. So sadly, the boy died, but he did show us that you can actually transplant a bone marrow that has the hematopoietic stem cells, and you can sometimes fix this. But the bone marrow has to be clean of EBV, of course. So now, what are severe combined immune deficiencies? They're basically deficiencies where you have your impaired your T or B cells, and it's sometimes you have impairment of your NK cells. It's not always, sometimes. And these are basically happening with loss of function mutations that are mostly in your T cell development. So there are many different types. There is this adenosine deaminase ADA deficiency. So this happens in 15% of SCID. So what happens here is patients have a loss of function mutation in the gene that encodes for ADA, this adenosine deaminase. This basically enzyme, what it does, it really kind of, let's say, stops the accumulation. It breaks deoxyadenosine. It breaks it. It's very important to break that because if this is not broken, you have a buildup of this, and this really can be toxic, specifically for T and B cells, for T and your B cells. So what happens is that these people don't have this enzyme, this accumulates, and this is toxic. So mostly your T and B cells are dead, and also it can also affect your NK cells as well. So you basically have all your lymphocytes, so your T, your B, and your NK cells that are being killed because of the accumulation of this very toxic metabolites, this deoxyadenosine. So this is ADA. Then you have X-linked SCID. So X-linked meaning that the gene that is linked to this disease is on the X chromosome. So this is a loss of function in this interleukin-2 receptor common gamma chain. This is a chain that is very common for many cytokine receptors for interleukin-2, but it's also common for interleukin-7, 15. I'll be going into a bit more details in this in a bit. But technically, you do not have functional cytokine receptors that are important specifically for your T cells. So your T cells actually are not, they're absent, completely absent, and your NK cells are also absent because they also need the gamma chain. B cells actually are still present, but they're not functional. They are impaired. People with X-linked SCID actually do have B cells, but they do not function because T cells, specifically CD4 T cells, are not there to help them anymore. So your B cells get impaired a lot. So this is why it's combined. So both your T and B cells are impaired, and also here you have your NK cells are also impaired. So this is your most common type of SCID. Then you have,
Doctor, can you repeat why the T cells are also impaired, please?
yes. So actually, for the X-linked SCID, I'll definitely will go into this a bit more. So if you didn't understand it now, give me 1 minute,
Deal, okay.
and I'll definitely go into this much more.
Deal, thank you.
No worries. So you have other defects, specifically in your VDJ recombination. So these are the RAG1 and RAG2. So if you guys remember, RAG1 and RAG2, they're very important, basically, for recombination of VDJ to create a B cell receptor or a TCR. So if you have a loss of function of RAG1 or RAG2, you don't have any more TCRs, no BCRs, so you have no functional T or B cells. So technically, this RAG1 and RAG2 defects gives you no T cells and B cells, so you don't have any T or B. But NK cells are not affected because NK cells do not have VDJ recombination. So these people have NK. Then you have radiation sensitive SCID. These are again loss of function mutations because of radiation, hence radiation sensitive. And these basically are basically in genes like Artemis, DNA, basically PKCs, and DNA ligase. These ones, we've heard about them. These are found in your VDJ recombination. These also help VDJ recombination. And again, we have the same effect here. No T cells, no B cells, but we have NK cells because NKs do not need um, VDJ recombination. So now going back into X-linked SCID, because this is the most common one. So this is very interesting because what happens, it's you have a mutation, a loss of function mutation in a gamma receptor. It's called the common gamma chain, or in short, we also call this CD132. This common gamma chain is a chain that is found in your interleukin 2 receptor, interleukin 4 receptor, 7, 9, 15, 21, and this TSLP. So interleukin 7 receptor. So you basically have this gamma chain that you see here in blue. It's a very common chain, so hence the name, that's found in all these different types of basically cytokine receptors. Basically, interleukin 7 and 15 and 2, they are really needed for T cell and NK cell development. B cells don't really need it. They don't need these receptors to develop. So this is why in XKID, B cells are not basically they have a normal number because their development is not being affected. T cells and NK cells that need interleukin 2 and 7 and 15, those they, they're not being active because this chain is not there, so this receptor is not able to bind to interleukin 2 anymore. So these are not able to, to develop. So T cells are not there, NK cells are not there. So what happens is B cells develop, but they're not able to produce antibodies because B cells need CD4 T cells. They need them. Sorry. They need CD4 T cells to actually produce antibodies. Well, you don't have T cells anymore. So B cells now, they're there, but they don't have the proper stimulus to create antibodies. So that's why these people do not have a proper B cell response. So this is X-linked. Then you have Omen syndrome, which is basically the mutations in RAG1 and RAG2. So again, what you have here is you do not actually, the RAG1 and RAG2, you don't have them. And what happens here, there's very limited VDJ recombination in T cells. So you do have a bit of T cells, but they're very little. They're not fully absent. There is very little of them. But weirdly enough, that the ones that you have, let's say the 2% that you have of T cells now in your body, they're autoreactive. Their TCR is able to recognize self antigens. And this is why a lot of people that have Omen syndrome have a lot of issues with autoimmunity because their TCRs are not able to actually recombine. They have a very restricted TCR repertoire, and most of these TCRs are going and basically binding self antigens. B cells are completely absent. Why do we get T cells, a bit of T cells and not B cells, even though it's in the RAG2, RAG1 and RAG2 are both in them? I really don't know. I've been trying to find this reason, but we still don't know why. But this is in the case of Omen syndrome. So these people, of course, have a huge susceptibility to opportunistic infections, but you also have a lot of graft versus host features, rashes, diarrhea, lymphadenopathies, a lot of these things because basically you don't have a proper T or B cells anymore. This is basically a very interesting case that me and you have worked together with. This is not an exam. This is purely just a nice clinical case that we found. This is a very, very interesting case. So Yuha got this boy. This boy presented with something called atypical X kid, meaning that this kid basically is a 16-year-old male that suddenly came into the clinic, and we found that this guy has kid. This is very weird. How the hell does a 16-year-old just now get diagnosed with SCID? Usually by 16 years old, you're dead if you're not basically being treated for that. Then we found out that he's atypical because he still is living and he still has CD4 T cells, he still has T cells, CD8 T cells, and he still has B cells, and basically NKs. But he has XKID, meaning that he has a mutation in his this interleukin 2 gamma chain, this common gamma chain. But his mutation was a missense mutation, is a completely new mutation that no one was able to basically publish it. So we went on and published it together in 2020, and we saw that this basically mutation, what it did is that his T cells and CD8 T cells still were present, but they were not so responsive, meaning that if you add interleukin 2, you should see CD4 T cells and CD8 T cells grow. So these two dotted lines are two healthy people. When you add interleukin 2 at high concentrations, they increase. You have a nice increase. But this is the patient, this bold line. It's very little. So this is having like 20%, this they're having almost 40. So a decrease in half. Same thing with the CD8 T cells. We see it in much more. These are going to 80%. These are still in almost like 30. So they saw, we saw basically that this kid is still having his CD8 T cells, still having his CD4 T cells, but they're not so responsive. They're not really working so well. But this didn't still explain to us why is this kid still surviving? Because his CD8 and CD4 T cells are still very impaired, but his NK cells is also impaired. His B cells were also impaired. So what's happening here? We saw, and I specifically worked this on a lot of this. This kid, for some reason, had a high amount of gamma delta T cells. These gamma delta T cells in your blood, they're about 2 to 4%. I found out that this kid's blood has about 40% of gamma delta T cells, and these gamma delta T cells are actually combating cancer. They're killing cancer, they're killing any infection, they're going haywire. To the point, what I did with this kid, I took his gamma delta T cells, and now I'm making new therapy because of this kid. So I went up to this kid and I told him, like, look, man, I'm really sorry that you're having a mutation, but I want you to know that despite this genetic lottery that you got of basically, let's say this not genetic lottery, more like genetic curse, you might be able to save people in the clinic because now we're using his blood to create a new therapy. So this was a very interesting case that we're still working on this. I still see this basically this Finnish kid. Well, more now, basically 16-year-old is more than a kid. So honestly, this was such a cool, let's say, kind of a case that we got presented with. And this is just to show you technically that doesn't mean that if you have one mutation in a gene, you're going to get a phenotype. You can get different arrays of phenotypes. So what are the treatments for SCID? Usually, as I said, they're very dangerous, so you need to treat them. So the main way is allogenic hematopoietic stem cell transplantation. So you transplant hematopoietic stem cells from someone else, hence allogenic. Usually, this is the best case, but not you don't have a perfect donor because, as we know, transplants are very MHC dependent. So we need someone that has the exact MHC, which is extremely difficult, and this can be very hard to find. So in certain cases, for example, with ADA, SCID, so people that have a, let's say, deficiency in this enzyme, this ADA, what we do is we do an enzyme replacement therapy. You're missing this enzyme, we just give you basically pills that have this enzyme. So we just supplement you with the enzyme in a pill or with an injection, and these people live normally. People that have, for example, this XKID, this interleukin 2 gamma chain deficiency, we're trying now to do gene therapy. So we use lentiviruses. These viruses are able to go and infect hematopoietic stem cells, and they're able to actually add a new functioning copy, a good copy of your interleukin gamma chain. This was basically now done in 2019. They did it on 8 infants. 7 out of 8 of them actually had their T cells go back to normality and their NK cells after 3 or 4 months. So this showed a very, very promising strategy. But again, gene therapy is one of those things that is controversial. People don't like it. There's a thing, but to me, I always think in this thing, once we have a technology, we're always going to use it. So I'd say give it a decade or two, this will actually become a new standard. And where anyone has SCID, will get this gene therapy. And now in Finland, basically, of course, as we know, SCID is very dangerous. So the earlier you're actually diagnosed, the better, because you do not want to get infected with a very nasty disease that can kill you because you have no immune cells. So to prevent that, in Finland, they've done now a new screen that I think it's becoming a huge thing in Finland, and mostly because Juha really pushed this in the parliament. But I think now a lot of European countries are using this. So what they do now is this is basically a newborn. They take a bit of blood and they look for these Tregs. These are T cell receptor excision circles. When we do this VDJ recombination, we remove a lot of VDJ segments that we don't want. We remove them. So if you remember, this is the RAG1 and RAG2, what they do, this kind of circular. Artemesis comes in and they cut and they remove basically VDJ segments that we don't want. Well, these are basically circularized, they're circles, and we get a lot of these. So if we have a lot of VDJ recombination, you have a lot of these T cell receptor excision circles. So if you have T cells, you should have a lot of Tregs. So what you do, you take the blood, we do this basically qPCR, so this quantitative PCR, and we measure through PCR how many Tregs do we have. If we see that we have, of course, a certain standard. If it's below the standard, we'd say that, hey, there's not a lot of T cells developing. If it's above the standard or, to the standard, perfect. Means you have a normal, basically, T cell compartment. So this is now the new way of screening for SCID. But of course, other than just these kind of X-linked or Omen syndromes, having any defect in your thymus can actually have a huge defect in your T cell development. Because as we know, your thymus, you have your thymical cortex, you have your thymic medulla, these epithelial cells over there that really help our T cells to develop. So if something happens there, our T cells don't develop. And you have this a lot with DiGeorge syndrome. DiGeorge syndrome is basically you have a whole deletion of one copy. So this is basically haploinsufficiency, in where you have a deletion of one copy of this chromosome 22. So this deletion removes a very important gene called TBX1. TBX1 technically is a very important gene because it encodes for proteins that help thymus development. So these kids do not have they basically have a very impaired thymus. Either don't have it, they're absent, or it's very defective. It's barely there. And because it's barely there, you have very little T cells. You don't have a lot of T cells occurring there. And of course, you don't have no CD8 T cells, no CD4 T cells. And this really also impairs your B cells because, again, as we know, CD4 T cells need to be present to have a good B cell response. So, in people with DiGeorge syndrome, they have B cells, but they're not producing antibodies because there's no CD4. Basically, of course, other than just these kind of symptoms of basically recurrent infections and everything, the thymus has a very important role with neurodevelopment, with basically and generally growing. So you have a lot of different types of symptoms going from psychiatric disorders, face dysmorphisms, heart defects, you name it. So honestly, diagnosing these kids are quite easy by just looking at them sometimes. But also you can have defects on T cell with your MHC2 and MHC1 defects. Because as we know, in the T cell development, so if you go back in over here, you have your double positive, negative selection. So you have your double positives, either they go to CD8 or CD4. And that all depends on MHC2 or MHC1. If you have MHC1, CD8. If you have MHC2, CD4. If you have a defect in one of them, you can have a defect in a certain subtype. So we see a lot of basically mutations that are affecting the MHC2 expression. We've seen it in where there are certain mutations in certain genes that are important in expressing MHC2. They regulate MHC2 gene expression. So what happens is that now these genes are mutated, they're not helping MHC2 be expressed. So we have a loss of MHC2. So in basically this double positive selection, we don't have no more CD4 T cells. So your CD8 compartment works normally because you have MHC1, but very little CD4. So you don't have any CD4 T cells. Your B cells are impaired because again, CD4s are very important for B cells. And these people have very, very severe, basically, complications. So this is very similar to what you get for AIDS, actually. Then you have MHC1 class defects. What happens here is you have mutations in your TAP1 and TAP2 gene. TAP1, TAP2, if you guys remember, these are transporters. They transport antigens from the cytosol to the ER to put it on an MHC. Because MHC1 will never leave the ER unless you put an antigen. So TAP really helps that. If you have a mutation there, no more antigens are going to the ER. MHC1 is stuck in the ER and doesn't go to the surface, to basically to the surface expression. So what happens here is that you don't have any CD8 T cells. Here you have actually a lot of skin ulcerations. Surprisingly, you don't have actually viral infections. And this is very weird because as we said at the beginning, that CD8 T cells have a very important role in killing viruses. But we see with these patients, they don't really have such a huge susceptibility to viruses. And this shows us that NK cells can actually do the work here because NK cells are very good at killing off viruses. Now, I'm going to talk about quickly the basically B cell, let's say, antibody deficiencies. Sorry, just quickly see the time here just to make sure that I don't go over time. Okay, perfect. So antibody deficiencies, these are basically, as we said, very, very common, happen in 65 to 80% of all PID people. So these basically give you a huge susceptibility to pyogenic bacteria. So these are bacteria that create pus. So these are staphylococci, streptococci. These are the ones that have literally capsules. Because they have capsules, they're not recognized by your phagocytes. So this is why your complement system and your antibody system are super crucial. And having one of these basically removed, you have a huge susceptibility towards them. So we have basically this Burton's X-linked amyoglobulinemia. So again, this is X-linked. And what this means is you have BTK. BTK is a very important signaling protein. So during your pre-B cell stage, your pre-B cell stage, you have a pre-BCR that once it binds to an antigen, it causes a whole signaling cascade, a big one. And a very important protein in the signaling cascade is BTK. If this is basically uh, mutated, it doesn't work. This pre-B cell is not able to now have a signaling and it stop, and the pre-B cell does not mature. So you have an arrest at your pre-B cell stage, and you do not have now any immature B cells or mature B cells anymore. So if you don't have any B cells, you don't have any antibodies. So usually, basically, as we said, this usually basically starts to have later on. The incidence is very rare. It's 1 in 150,000 patients. Usually, basically, these people, they can survive by coming into the clinic every 6 weeks, and we literally just give them a big bolus of antibodies, a massive amount of antibodies against almost every single bacteria that we know. And we give this either through IV or through basically subcutaneously. So their treatment is quite simple, and there's a nice procedure for that. Then you have another one, this PU1 mutation. PU1 is a very important transcription factor. It's a very important transcription factor that regulates your myeloid, but also your B cell development. So we see that there's a loss of variants in this PU1 transcription factor. And this basically what it does, it reduces the number of B cells, but also dendritic cells. So these patients do not have a lot of B cells or dendritic cells. So again, they basically have no antibodies in the system. We call this a gamma globulinemia. So little antibodies in your blood. We also have a lot of issues with basically not in your B cell development, but as we know in your B cells, we know them that they are in this, let's say, kind of default switch of producing only IgM. For them to produce IgG or IgA or IgE, they need to go through this class switching. They need to switch. and they need to make sure that they go from IgM to something else. If you're with a bacteria, you want IgG. If you have a mucosal bacteria or virus, you want IgA. So they need to do this class switching. And there could be issues with the class switching. So what happens is that you have B cells that are producing IgM antibodies, but that's it. And an example is your hyper IgM syndrome. These patients basically have B cells, but they have a mutation in either CD40 or CD40 ligand. CD40 ligand is X-linked because the gene encoding for CD40 ligand is in the X chromosome. So we see here in your immature B cell and your CD4 T cell, CD4 T cells and specifically your T follicular cells, they love to help immature B cells to actually, let's say, mature, to become more, to do the class switching. They really help them to actually become much more, let's say, IgG producing or IgA or IgE. If a mutation happens in CD40 ligand and CD40, which is the connection between your immature B cell that is IgM and your CD4, there's no more class switching. So these immature B cells will only produce IgM because no class switching is happening. So they don't do any more class switching. You also have mutations in basically this AICDA gene, which basically gives you this gene, this AID. We spoke about AID. AID really helps in also class switching. So if you have mutation in AID, you do not have any more class switching. You have a lot of IgM. Either you have normal amounts or you have high serum IgM, but that's it. You don't have IgG, no IgA, and no IgE. Now we're going to go into more Tregs. Tregs, as we know, are extremely important cells when it comes to inhibiting. They inhibit basically your myeloid cells, your T cells, your B cells. They stop them from overreacting, hence their name, regulatory T cells. And these Tregs, they are CD4 T cells, but they have a very important differentiation, which is FOXP3. So we've spoken about FOXP3. FOXP3 is a very important transcription factor. It makes Tregs. They make them basically very regulatory. They help them transcribe all the important genes for regulating immune responses. So we see a lot of deficiencies in them. So we have this IPEX syndrome in where you have a loss of function in FOXP3. So you do not have any more FOXP3. These Tregs do not have any more. Basically, they're not functioning anymore. So you lose it. So you don't have any more peripheral tolerance. So you start to get type 1 diabetes, eczema, all these different types of autoimmune and basically autoinflammatory diseases. Then you have CD25 deficiency. CD25 is interleukin 2 receptor alpha. Please don't confuse this with the gamma. Alpha chain is only found in interleukin 2. The gamma chain is found in other cytokine receptors. So this alpha chain is very specific to interleukin 2 receptors. So FOXP3, so Tregs need interleukin 2. They are very, very, very sensitive. You remove interleukin 2, they will not survive. So now you remove the receptor, they do not function. And again, you get a lot of immunity, basically autoimmunity, and a lot of basically kind of, let's say, susceptibility to infections. Basically, you also have CTLA4 haploinsufficiency, and where you have a genetic defect in one of the genes in CTLA4. So as we know, Tregs, what they love to do, they like to stop CD8 T cells from doing their job. They do this either by secreting interleukin 10, but also through CTLA4. CTLA4, as we know, it really, really likes to bind to basically your T effector cells. They love to kind of stop them. They stop them from doing anything. You remove CTLA4, you basically now the Treg has lost a very important protein that it's been using to stop immune responses. So again, now your Tregs, they are not so effective, they're more impaired, and now you have more autoimmunity. So as you now have realized, I've been speaking a lot about there's a lot of autoimmune manifestations in this primary immunodeficiencies, a lot of them. But why? Why is that? So we understand for Tregs why you would have it. But why do we have it, for example, in Omen syndrome, where there's defects in their B and T cells? Why do you have it there? Why do you have it in other ones where you have defects in your B cells or something like that? Well, there are six different, let's say, hypotheses. First one is that, for example, we see in Omen syndrome, you see that you have a very weird T cell repertoire. The TCRs are not that vast; they're very little because there's not a recombination, so there's not you don't have so many combinations, and most of them are very towards the self antigens for some reason. The second one is that we have an abnormal response to cellular and pathogen-derived debris. So there's a lot of cellular, let's say, dams or a lot of these kind of things. When you have apoptotic cells, they release a lot of these things or a lot of molecules that can cause immune activation. We also see a lot of pathogens are there. They're not being cleaned up. So they can keep pushing your immune system more and more and more because you don't remove them. Sometimes we see in hyperactivation of lymphocytes. These are specifically mutations in your PI3K gamma subunit. So this is a very important subunit in your lymphocytes. They push them. This is where the T cells and B cells become very active, but not really towards infection, but towards against us. You have a lack of central tolerance. So technically, your central tolerance is mostly happening in your thymus. So we see in the partial DiGeorge syndrome where you have your thymus is not there present. Your thymus is very important for central tolerance. It tells what TCR should go or not. So this is the negative selection. There, they really it's gone. You don't have any more central tolerance. So a lot of autoreactive T cells will escape. You also have no more Tregs. So as we say, you have a lack of peripheral tolerance. Or sometimes, because you're now infected with so many different types of basically microorganisms, it could be that because you have an increase now susceptibility, that you might basically come and get infected with a virus or a bacteria or a fungi that has a similar protein to you, and you induce this molecular mimicry that we spoke about before. Because now you have a higher chance of getting more infections and more different types of basically microorganisms to infect you. So these are why we see this quite often. It's quite interesting. Now, for the last, let's say, 5, 10 minutes, I'm going to quickly just go with other ones that you see technically with your myeloid compartments. So you see GATA2. GATA2 is a very important transcription factor. It's a transcription factor that really pushes hematopoietic cells towards more your dendritic cells and monocytes. So what you see here is your GATA2. If you have a haploinsufficiency there, you have a loss. You don't have any more dendritic cells. You do not have actually a lot of B cells and NK cells because GATA2 also helps them, but it's mostly dendritic cells. It's usually there. And because you don't have dendritic cells, T cells, T cell numbers are normal, but they do not function because dendritic cells, they give MHC1, they give MHC2, they really help T cells grow because they are antigen presenting cells. So T cells really don't have, actually, they're not that active. They're there in normal numbers, but they're not active. And usually these people are need to be treated with hematopoietic stem cells because you have many different types of immune cells being affected here. So it can be very dangerous. Then you have, of course, defects in your phagocytes. These could, for example, could be deficiencies coming from production of phagocytes, so from your macrophages or monocytes, defects in them moving. So you can have many different, basically, mutations in their ability to move. You can have actually basically also defects in their PRRs, the pathogen recognition receptors. They're not able to recognize anymore. Or defects in their phagocytosis killing. So the machinery to do the phagocytosis is gone. So could be many different types of defects. I'll give you here an example with neutrophils. Neutrophils, when they are activated, they release basically a lot of different granules, a lot of granules that are releasing granzymes and all these different things that kill. They have basically, we see that there's a mutation specifically in this ELANE. ELANE it encodes for this neutrophil elastase. And this protein really is a component of the granules and very important in degrading phagocytosed microbes. So it's a very important thing for phagocytosis. So we see that if this is actually mutated, you're not able to destroy these things that we're phagocytosing. So neutrophils are gone. A big portion of your phagocytes are gone. You have a lot of pyogenic bacterial infections then. We see a very, let's say, group of diseases, which we call leukocyte adhesion deficiencies. These are basically divided into three different types. I'm not going to go into the technique, into the specifics of them, but technically, you have defects in integrins, in these very important, basically, proteins that help these leukocytes, specifically macrophages or monocytes, to move. As we know, in inflammation, they need to move, they need to roll. This is all done through integrins. So what happens is that it's gone, they're not able to go to the site of injury. So you have a lot of susceptibility now to bacteria, fungal infections, and all these different types. You also have a lot of defects in toll-like receptor signaling. So as we know, we have a lot of toll-like receptors that bind to different things, and they all basically can induce a signaling cascade to make, let's say, your monocyte or your macrophage active. And a lot of them have this MID88 or IRAK4. These are signaling, basically, um, proteins. They're very important in this whole signaling cascade. So this is where IRAK4 is. MID is over here. It's shared among a lot of them. And if these are mutated, you don't have any more signaling. So your phagocyte is not able to now detect anything. So they cannot do much phagocytosis anymore. Another thing we see a lot is in chronic granulomatous disease, CGD. So macrophages, they produce, or also neutrophils and monocytes, they produce a lot of reactive oxygen species. And they do this by using this NADPH oxidase, this huge machinery that produces reactive oxygen species. So we see that there's a mutation here that literally stops it. You don't have any more reactive oxygen species. Your phagocytes are now crippled. So this is basically a lot of another example here. And now finally, the last thing I'm going to talk about is your complement. Complement system, as we know, there you have three different basically pathways, your classical, your lectin, and your alternative. A lot of mutations can happen in C1, C2, C4 that are mostly in your classical, mutations in your lectin or your alternative pathway like factor D or P. But the majority that we see is actually in your C3. C3 is one of the biggest mutations that we see there. And C3 is the one that combines all three, as we know. And if you have mutations in your C3 and your C5, 6, 7, and 8, or 9, these ones, any deficiencies here, you usually have a lot of manifestations. If you have basically mutations in C1 or MBL, you might have, but not really, because okay, if your lectin pathway is gone, you still have your classical pathway. You have another pathway that's still in some sort of way kind of making up for that deficiency. While here, not really. You don't have anything that's making it up. So you see a lot of people having much more in the C3 and in their basically either your C5, 6, 7, 8, or 9, these ones that are more common. If you have any defects here, you have literally a 10,000-fold increase risk for Neisseria meningitis. Neisseria meningitis is very prone to be killed through your complement system. Our complement system is extremely good at killing it. So usually when we see a patient that has Neisseria meningitis, quite often we say that this person has definitely a complement deficiency and mostly pertaining to here. So it really helps us understand it because Neisseria meningitis is capsulated, it has a capsule, and it really does not, your basically phagocytes are not able to really come up and kill it up. So your complement system really helps there in that kind of sense. So, guys, thank you so much for your attention. And if there's any questions, please let me know.
Yes, doctor, I have a question.
Tell me.
Regarding the complement deficiencies, why
Yeah,
in the from C5 to C9 we only have deficiency or infection in the Neisseria and not other bacteria?
that's a very good question. Basically, because other bacterias they're not so encapsulated per se. Like, of course, you still have staphylococcus and streptococcus, but those ones, your antibodies really can take them off. For some reason, your antibodies really can bind to them, and they can be once the antibodies bind to them, phagocytes can do much. For some reason, with Neisseria meningitis, even though the antibodies are binding to it, still phagocytes find it hard to eat it up. So it's really your complement system that really comes there to kill it. Neisseria is a weird bacteria that really is able to escape your macrophage quite well. So that's why it has a high dependence on complement compared to, for example, other encapsulated bacteria like Staphylococcus or Streptococcus. Those ones, despite being encapsulated, your antibody binds, and once that bounds, it helps your phagocytes to kill it off. So that's why, okay, if your complement is deficient, you can still use your macrophages. Does that make sense?
Yes, doctor. Thank you.
No worries. Any question, guys? Anything you guys want me to go over, or just any curiosity that you might have?
It's all clear. Thank you so much.
Perfect, guys. Perfect. I'll put up the recording up
Thank
by
you,
today.
doctor.
Thank you, guys. Have a great day.
Thank you,
Bye
doctor.
Thank
bye.
you, doctor.
Bye.
Bye.